Kanti team for inviting me. It's my pleasure to come to Calcutta and meet my friends. So, after the fantastic talk by Dr. Rahul, I will little bit talking on very basics of DSA. This is Digital Subtraction Angiography. So, we'll discuss this Cerebral DSA under following headings: introduction, vascular access, aortic arch catheterization, supra-aortic vessel catheterization, what are the indications of cerebral DSA, what are the contraindications of cerebral DSA, and what are the complications or risks exposed to the DSA. So history dates back to the 18th century rather, although most of the credit goes to the cerebral DSA to the Egas Muniz, who was the Portuguese neurologist, but even the DSA or even the angiography or conventional angiography has been performed in the 18th century, but the first discussion of the cerebral angiography was detailed by the Egas Muniz in the 1927. The Gazi Yesargir was one of the person who performed more than 10,000 angiograms in 11 years from 1953 to 1964, and in late 1960s, first transfemoral angiogram was performed, and the DSA, which is advent, came in 1980. So he is the Egas Muniz who performed the first cerebral angiography, and he was from the Portugal, and he was a neurologist. And these are the angiogram films by the Egas Muniz, and we can see that vessels are not very clearly visualized. Although we can see there is a posterior communicating artery aneurysm, but vessels are not very clearly visualized because it was a not substructed angiogram. And at the time, the angiogram was done by the diet puncture. So you have to do the diet carotid puncture, or you have to do the diet vertebral artery puncture to see the posterior subcutaneous stroke. But the credit of placing the Cs in the vessels goes to the Selinger in 1953. So he invented the Selinger technique to placing the trans-arterial catheter, and then the angiography become quite easy. From the very beginning, now we have advanced up to the modern angiography machine, and now we have the biplane machine like in this institute. This is the SMS DSA machine of the biplane machine at the SMS, and now with the advent of newer catheters, now the angiography is become more and more simpler and more safer. So we have from the this to we have from now we have developed from here. So you can see the difference between this non-substructed angiogram and substructed angiogram. Here we can see the vessels not very clearly. Now with the distal subtraction of the bony landmarks, now the vessels are very clearly visualized. So first we discuss the vascular axis. Most of the time the femoral axis is used, but radial axis is often used by the many operators. By Dr. Rahul, Dr. Kalyan is one of the person in our country, and anatomist snuff box is one of the access to the radial artery, and rarely we can go for the direct carotid puncture. So first we must understand the anatomy of the femoral artery, and this is the anterior supine iliac spine. This is the pubis symphysis. In middle we can palpate the femoral artery. Middle to the femoral artery is the femoral vein, and we have to puncture the femoral artery around 3 cm below the inguinal ligament. If you see this anatomy, the femoral vein is the medial, femoral artery is lateral to this, and femoral nerve is the most lateral to. When we are puncturing the vessel, we have to be sure that we should be around 1 inch or 3 cm below the inguinal cord, so we can hit the common femoral artery. If we are more proximal, then even may pierce the profunda femoris artery, and the blood will not come out very nicely. Or if we are more distal, we can just puncture the right artery, and then chances of peritoneal hematoma is very high. This is the femoral artery sheath, and it has many components. So this is introducer sheath. This is the puncture needle. For the adult, it is 18 gauge needle. Then it has a dilator, and then it has a J-tip wire along with a straight. So first we have to flush sheath with the venous saline, and we should be sure that there will be no air bubble in the sheath. After that, below the 3 centimeter inguinal fold, we inject the local anesthesia, 2% lidocaine, and it is always important to make a very good wheel so the patient will not feel the pain. And when we are injecting the local anesthesia, it is always important to suck the blood in between to show that we are not intravascular. These are the various steps of placement of the femoral sheath. So when you puncture the artery, femoral artery, the blood, gush of the blood will come out. Then we take the guide wire over it, and then we take out the puncture needle. On the guide wire, we introduce the femoral sheath, and then we take out the needle, the guide wire as well as the catheter at the same time, and secure the sheath, and flush with the venous saline. So beginning with the DSA, aortic arch angiogram is important because we can find out what type of aortic arch is and if there is any atherosclerotic disease at the aortic arch. For taking the aortic arch angiogram, one catheter is called pigtail because shape of this catheter is like pigtail and it has 5 holes. So when you inject the contrast will go in the different direction of the aortic arch, and we can have a very good arch angiogram. So this is the kind of arch angiogram we usually take for the DSA. If you're single plane, you can keep your C-arm into the 35-degree angle. But if you're biplane, you can keep one arm in the left entry oblique and other arm in the right entry oblique, and you can get good quality of aortic angiogram. Then there is various type of aortic arches. This is called type 1, type 2, and type 3 arches. How we decide these arches? So this is the superior margin where the supraortic vessels are arising. This is the inferior margin of the aortic arch. So if the brachiocephalic trunk or innominatory trunk is arising above this, or all supraortic vessels arising above this upper border, it is called type 1 arch. If the supraortic vessels or the innominate artery is arising below upper line and below line, we call it type 2 arch. And if all the supraortic vessels arising between superior line and inferior line, then we call it type 3 aortic arch. There are types of diagnostic catheter, what is called simple curve catheter and complex curve catheter. So simple curve catheter, we can see there is only one curve here, and the complex curve catheter, we can see here is 2 curves. So there is a primary curve and there is a secondary curve. So the simple curve catheters are used for the type 1 arch angiography, but when we have type 2 or type 3 angiography, then we have to use the complex curve catheters. If you go more detail in the diagnostic catheters, we have many parts. So this is called tip length. Then we have primary curve, then we have secondary curve, and this is called tertiary curve. And the length of these catheters is usually used for the cerebral angiography is 100 to 125 centimeters. Another catheter used for the renal artery angiogram or for the spinal angiography is called the cobra catheter. The length is around 65 centimeters. So these are the various types of the catheters which is used for the cerebral angiography. Most commonly used in the neurology practice is H1 or called head enter. Then for the difficult task type 2 and type 3 arch, you can use SIM 1 catheter, SIM 2 catheter, or SIM 3 catheters, or sometimes you can use the word catheter. And the pigtail catheter is one of the catheters which is very oftenly used in all the type of the arches and very good catheter for catheterizing even type 3 arches. So if type 1 arch, the head enter works very well. So what you have to do, you have to place your catheter in the aortic arch, and then just you have to drop the catheter, and the most of the time you are easily able to catheterize the supraortic vessels of the innominate artery, and then you catheterize the right common carotid artery, go to the right subclavian artery, and then if the ostium is normal, then go to the right vertebral artery. Then just drop the catheter to the left side, and you are able to catheterize the left common carotid artery, and drop more, then you are able to catheterize the left subclavian artery. So simple arch. But if there's a difficult arch, then you have to use the Simmons 2 catheter or Simmons 3 catheter. When there's a bovine arch or when there's a tortuous arch or the patient has more than 50-year age. So for this, you have to make the shape of Simmons catheter. So first you have to advance your Sim 2 catheter beyond the supraortic vessels, then make more arch, make the shape of it, and then throw the catheter to the supraortic vessels. So first you have to take the extracranial angiogram. You must be very sure that the ostium of the carotid artery or internal carotid artery is normal before taking the intracranial view. And then take the internal cranial shot. If you are taking DSA, you have to be sure that you have to take the early artery phase, late artery phase, capillary phase, and the venous phase. So all phases must be documented very well in the DSA. After that, take left subclavian shot or right subclavian shot. See the ostium of the vertebral artery, and the vertebral artery ostium is normal. Then only advance your catheter in the V2 segment of the vertebral artery and take the extracranial angiogram of the vertebral artery. And after that, you can take the intracranial angiogram of the vertebral artery. So when you are performing the DSA, it is always better to start with the aortic arch. You can take the pigtail catheter because sometimes the supraortic vessels are so much atherosclerotic. If you manipulate your catheters blindly here, then you may develop multiple microemboli like this in case, and patient may have multiple infarcts. When you are performing the cerebral DSA of the ischemic stroke patient and with suspected carotid artery bifurcation, you have to take the multiple projections. So AP and lateral are the standard projection, but along with that, you have to take the oblique injections, right anterior oblique and left anterior oblique, because sometimes the stenosis is well seen on these oblique projections rather than AP or lateral projections. When you are performing DSA for the stenotic disease, you must measure the stenotic, what the percentage of stenosis we have. We have various methods of measuring the stenosis, but the Lancet criteria is the best for measuring the stenosis. This is the maximum area of stenosis. This is the normal distal diameter of the internal carotid artery. So the formula to measure the stenosis is B minus A by B into 100%. Then after taking extracranial injection, you must take the intracranial injection to see if there is a good correlator and if there is no intracranial atherosclerotic disease. After that, anterior subduction, you must go for the posterior subduction. First take the subclavian view, see the vertebral artery ostium is normal or not. If the vertebral artery ostium is normal, then only enter to the vertebral artery, and then take the AP and lateral view of the vertebral circulation, and sometimes you require the oblique view to see it. Collateral assessment is again very, very important, and this is part of the DSA examination, and we must examine the circle of Willis. We must see the pile collators, as Dr. Rahul was saying, various leptomeningeal collators, and we have to see about the extra to intracranial anastomosis, which are the commonest anastomosis to the middle pharyngeal artery, to the ethmoid branch of the ophthalmic artery, facial artery to the occipital artery, and acidic pharyngeal artery to the cavernous and peterocysis segments. So circle of Willis demonstration is very, very important, particularly when we are from the cerebral DSA. But this circle of Willis is hardly complete in 50% of the cases. In 50% of the cases, this circle of Willis is incomplete. So you may have the hypoplasia of the posterior communicating artery, or you may have hypoplasia of the anterocerebral artery, A1 segment, or you may have fetal PCA, that the PCA is supplied mainly from the anterior circulation to the BCOM, and it is not filling integrally to the vertebral circulation. Or we may have combination of these anomalies in one of the people, like we have no A1 here and no BCOM here. So multiple anomalies of the circle of Willis is also feasible in one of the patients. The leptomeningeal collateral assessment is again very, very important when the vessels are occluded, and we can see these are the leptomeningeal pile collators, which are going from the PCA territory to the middle cerebral artery territory and also PCA territory. Hypoperfusion stroke, when we see the MRI like this, when there is a internal watershed zone, it is always important to see the carotid artery, and sometimes we get various severe stenosis of the carotid artery. Or when we get the embolic stroke like this, then there is a chances we may get the ulcerated plaque at the carotid lesion. If there is no significant stenosis, but if there is ulceration, then we make an artery to artery hemorrhage of these type of the cases. Sometimes we may have a tandem stenosis, like this case, we have the stenosis at the origin of the ICA, and there is a stenosis at the cavernous segment of ICA. So tandem stenosis is not again uncommon, particularly those patients who are atherosclerotic disease are not well controlled. Or sometimes we can see the intracranial atherosclerotic disease, like in this case, the middle cerebral artery, small segment stenosis here, or the stenosis at the V4 segment of the vertebral artery. Then, to demonstrate subclavian artery steal, DSA is one of the very good modality. Like this patient, 60-year male, hypertension and diabetes, recurrent ataxia and vertigo. So when we take the right subclavian shot, we can see the right vertebral artery is very good. But when say the left subclavian artery, there is a very severe stenosis of the left subclavian artery before the origin of the left vertebral artery. So we'll take the right vertebral artery injection. When we see the reversal of the flow is not going antegrating the basal circulation, but most of the flow is reverted in the opposite vertebral artery, and even from this, the subclavian artery is also clean. So this is called subclavian steal syndrome. DSA is also very helpful in the subretinal disease to define the morphology of aneurysm, particularly in cases where the CT or MR angio is negative. If the aneurysm is less than 4 mm, it is likely to miss the CT angio or MR angio. So any patient with the subretinal disease, CT angio and MR angio is negative, you must subject this patient to the DSA, and then you are likely to miss the blister aneurysm, which are very small aneurysms. So indication of the DSA in the aneurysm assays to see the size of the aneurysm, shape of the aneurysm, orientation of the aneurysm, to see the neck and any important vessels, parent vessels arise from the neck, how the parent vessel is, what is the morphology of the, what is the size and morphology of the parent vessel, to assess the collaterals, to assess the anatomical variations, to see for the vasospasm, and sometimes these subretinal disease may be other vascular disease like fibromuscular dysphagia, vasculitis, and sometimes there is an additional aneurysm we can find on the DSA. So for the DSA, we must define the morphology of the aneurysm very clearly. We have to define this neck and sac and measure the neck of the aneurysm to see which type of the devices is useful for the coiling of these type of aneurysms. Sometimes the multiple aneurysms are not very uncommon. Just like this example, 32-year male patient have subretinal hemorrhage. You can see hemorrhage on the left side. The CT angio shows aneurysm in the supraclavian segment of the left side. But when we perform DSA, we found two more aneurysms. So this is the aneurysm which was seen on the CT angio, but we can find one parophthalmic aneurysm on the left side, and this is small aneurysm also on the right side. So ultimately, we have coiled the all three aneurysms in one set. Blister aneurysms are not again very uncommon if you see very methodically. So 35-year male, subretinal hemorrhage, grade 1 SAS, diffuse SAS, CT angio was normal. When we perform the DSA, we can see in the medially projecting small blister-like aneurysm here. SAS and with the CT angio normal, DSA is one of the mandatory things. Like this case, 52-year male, patient has minor trauma, severe headache. He was absolutely conscious, no deficit. CT angio was normal, and we performed the DSA. We found that the contrast is stagnating into the eye cup, the anterior cerebral artery, and possibly there was a dissection. We repeat the DSA after 4 weeks, and this contrast stagnation become absolutely normal. Another example of the reports on DSA, 70-year male, we can see there's a ventricular hemorrhage here only. Predominantly, it is a ventricular bleed only, but CT angio was normal, but when we performed the DSA, we found there is a dual fistula. So this is a meningohypophyseal trunk which is supplying the venous system, and there was a marked cortical venous reflex. So even with the ventricular hemorrhage in the young patient, when there is no hypertension, we have to perform the DSA. So there is a dual arteriovenous fistula with cortical venous reflex. This is not uncommon thing. We treat many patients with a chronic CVT, but when we perform DSA, we found there is a dual fistula. So particularly those patients who are not responding to anticoagulant therapy and the symptoms are progressive, a patient is having visual loss, then it is always better to perform the DSA in the chronic CVT, and then you can find fistula here, which is not uncommon finding. This is the one case with 60-year male and present in the neurology department with the dementia, and when we done MRI, we can find there's a lot of fluids here. And when we perform the DSA, we can find there's a dural fistula. So patient with the dementia, you have to look for the fluids very carefully, and sometimes you can find the reversible cause of dementia in form of dural artery fistula. Another not uncommon thing in female, particularly if they present with the interventricular hemorrhage, the most common diagnosis is moya disease. So we can found this puff or smoke here. So particularly the young lady and presenting with the interventricular hemorrhage, the moya vessels or moya disease is not uncommon to find it. Again, one of the indications for DSA is the vasculitis. So this is the case with classical beaded appearance where the ANA and DSDNA was positive, and patient has multiple small subcortical stroke, and we found there's a multiple classical beaded appearance. So DSA is also helpful to diagnose or establishing a diagnosis of vasculitis in these cases. DSA is also helpful for the tumors also, but for the pre-surgical embolization. And the classical picture of the DSA in the tumor is the sun-based appearance. So there's a marked vascular plus here, tumor plus here, and then you can pre-surgically embolize these cases to have the neurosurgeons. Carotid cavernous fistula, again, the gold standard to diagnose as well as treat is the Cerebral DSA, and you can see here the prominent supraophthalmic vein, inferior ophthalmic vein. It is communicated with the cavernous sinus, inferior petrosal sinus here, then posterior. Another indication of the Cerebral DSA is inferior petrosal sinus sampling. We do at least 1 or 2 cases in a month of inferior petrosal sinus sampling different from the endocrinology department. The indication for inferior petrosal sinus sampling is first to diagnose that the Cushing syndrome is peripheral in origin or central in origin, and if it is central in origin, which lobe surgery has to be done. So here there is the 2 diagnostic catheter in the inferior petrosal sinus. You can see the intercavernous connection, and it will take the 3 samples, one from the peripheral circulation and 2 samples simultaneously from the both inferior petrosal sinus. We provide a detailed report, and this is the DSA format and as we perform this complete description of the procedure. And this is the chart we made to see each and every segment of the vasculature. So this for the extracranial circulation, we can see these all 3 segments of the vertebral artery, all 5 segments of the internal carotid artery, right side, left side, and the left subclavian artery. And for the intracranial circulation, again we see the intercarotid system, intracranial segment, vertebral artery, visual artery, all segments, proximal, middle, and the distal segment of the vertebral artery. How the PCA is looking. If there is any stenosis in this artery seen or not, occluded, or vessels in proximal. So we have a very extensive table-based description of the DSA, and then we mark where the stenosis is or aneurysm is on this diagram, as the coronary people do very often. There is some contraindication of the DSA, bleeding disorder, thrombogenic conditions, some local skin infection, abnormal renal function, CSF, allergy to contrast, pregnancy, and if there is a known palpable pulses. There are some risk of the DSA also. Usually we have to keep our risk less than 1%. This is one of the C's where they describe the complications around 2%, which is not acceptable at least in DSA. It should be less than 1%. The various complications may be reversible neuroscience deficit, like TIA, extremely rare to have a permanent neuroscience deficit with the DSA. Then you can have renal failure, artery subfusion, arteriovenous fistula, pseudoaneurysm, and local hematoma, which requires transfusion or surgical intervention. But keep in mind that risk should be less than 1%. Otherwise, you have to revise your technique again and again to make the procedure very safe. Thank you very much.